Good morning, everyone. I'm Ahmad Younes. I'm one of the interventional cardiology fellows at University Hospitals in Cleveland. And today we'll be presenting a quick case of 65-year-old female who actually was referred to us for acute limb ischemia. So this lady, 65-year-old, she's known COPD, run-of-the-mill, Northeast Ohio, comorbidities, diabetic, hypertensive, dyslipidemic, peripheral vascular disease. She did have actually bilateral iliac stents placed in November 2017. She did okay for some period of time, then represented to an outside hospital with lower extremity pain, thought to be acute limb ischemia. So her vitals upon transfer, she was hemodynamically stable. Exam is pretty much negative. She does have 2+ femoral pulses, absent distally. Her home medications include aspirin, lisinopril, albuterol, and heparin and Plavix were actually initiated at the index hospitalization prior to transfer. She still smokes. She's 45-pack-year smoker, and labs are pretty much normal. So her outside hospital angiogram, this is right before transfer. So pretty much left CFA axis. There's not much flow going up in the aorta. They did balloon angioplasty for both existing stents, and this is the end results they ended up with. There is better flow, but it's still unclear what's happening in the aorta there. And the differential at that point would have been a dissection. Did they dissect on the way up? Is the aorta? This is a dissection flap. Or there's just thrombosis in her current stents. So on arrival, she gets an ABI study and monophasic waveforms at the ankles. ABI is 0.26, 0.31, and the TBIs are pretty much flat lines. And it doesn't really require a cardiologist to know that flat lines is a bad sign. So the plan on transfer, we entertained few options. Vascular surgery to do an aortic bifemoral bypass. Remember, this lady is on Plavix already. Thrombolytics, still unclear how's the chronicity of her thrombus have been there. Or endovascular interventions. So prior to transfer, the patient was on heparin. She did okay for some period of time, then on heparin, then later decompensated. So she got transferred to us on heparin. We took her to the cath lab. That was a late cath lab activation, but bottom line, we go left femoral approach. This is the tracings that we got from the femoral sheath, and the pressure is close to 30. There's not much perfusion distally. But the angiogram, the first shot, and I think it played already, we don't see any flow upward. So at that point, we started going up with a woolly wire with some Navicross support. And the way the wire was interacting here, it was still unclear if it's interacting with the stent struts or with the luminal thrombus or just it's going behind the stent. But our aortogram just confirmed that we're luminal in here. So on both sides, bilateral, we performed extensive debulking using mechanical thrombectomy and using the penumbra device. So it's an 8 French system that goes up with a separator, trying to mobilize the thrombus, hoping to aspirate somehow. And we did that on both sides. We had a little complication doing all these maneuvers. The separator actually got dislodged, and eventually able to retrieve it outside of the body with no difficulties. So balloon angioplasty first with 7/0 balloons, both sides kissing at nominal pressures. We did just understand the mechanism of failure of the stenting. We did perform some IVUS run. And this is in the aorta here. We see a good amount of thrombus and the stents pulling back down to the bifurcation. There's still thrombus in the stents themselves, but there is significant undersizing of the iliac stents in the proximal iliac compared to the native vessel size. And we thought that's probably what's the mechanism of failure. The reassuring portion of this is we know that we're luminal. We're inside the stent with our wires and catheters. So balloon angioplasty performed, kissing balloon, and this is the angiogram that we ended up with. We finally deployed the 8mm stents, creating a new carina, which we tried to avoid as much as possible. Given the amount of thrombus in the aorta and the pathology that is there, we did create a new carina, post-dilator with 7/0 balloons, and these are the final angiographic results, which looks pretty much different than the presenting one. And these are the pressure tracings from both arterial sheath and her groin. We see a good dichrotic notch, and this is comparable to her upper extremity blood pressure. So ABIs prior to discharge, It's up to 0.85, 0.95, good dicrotic notch, triphasic waveform. Even the PVRs goes straight up and goes back to the baseline. So her discharge medications and follow-ups, she got discharged on a good mix of heart failure medications for her comorbidities. Antithrombotic therapy, it was just conversations to come up with a good regimen for her. Eventually, she got discharged on aspirin, Plavix, and Coumadin for 1 month, discontinued the aspirin, continued Plavix for a full year, then switched back to the Coumadin aspirin afterwards. She was seen on the follow-up afterwards. The patient is doing great. She's very thankful for what was done for her. Thank you.
So very interesting case, you know, a question regarding why we chose penumbra as compared to other devices.
So that's a very good one. I think we suspected at that point a heavy thrombus burden, and the penumbra device is an 8 French system. We thought we're going to be needing this much aspiration just to get things out.
Yeah, no, the take-home points are actually great, and this is a big problem with iliac CTOs and iliac stenting, that they're undersized.
Yeah.
And this happens, and penumbra is a great choice because other devices are not 8 French, and the scepter really helps in taking on whatever clot is there. The other thing you guys used was IVUS, which is very important because that's one of the main reasons why iliac stenting, and you have all these cases coming back that are undersized, because nobody applies IVUS to these lesions, and that's when you find out what the real size. It's a good case, really good case.
Thank you.
I agree. The use of IVUS there, I think, is a big teaching point to help clarify your pathology. That's really important.
Thank you.